All right, good morning, everyone. Welcome to Treating Resistant Hypertension. If this is not the breakout session you're looking for, please message the panelists so we can help you get to the right place. While we wait for people to switch into breakout rooms, we'd love to hear from you. So let us know in the chat box what organization you're with, where you're from. We're expecting people from all across New York State today. And please make sure to select all panelists and attendees so we can all see your message. You can also use the chat box to ask questions throughout today's session, and we'll get to those during the Q&A portion at the end of Dr. Drury's presentation. So now please welcome Dr. Drury.
Great, so thank you so much for joining me today for this breakout session. As has been mentioned, the topic of this session is treating resistant hypertension. And as you can imagine, this is quite a large topic, so I have chosen to focus in on what I think are pearls for treating this disease, as well as some of the more recent updates over the last 5 or so years. And with that, we'll go ahead and get started. So these are the objectives for this session today. First, I want to talk about how to accurately diagnose resistant hypertension. And one of the important features of this is to appropriately exclude what we call pseudo-resistant hypertension, and I'll go through some definitions there. Second, I'll be talking about what is an appropriate secondary hypertension workup in the context specifically of resistant hypertension. And then finally, what I think is probably the meat of this presentation and what most of you are hoping to learn from is utilizing key lifestyle as well as medication strategies in the treatment of resistant hypertension. Resistant hypertension is quite common. It's a highly prevalent disease, and it's important to remember that this is associated with a significantly increased cardiovascular disease risk, both cardiovascular disease morbidity and mortality, in contrast to patients who have essential hypertension. The prevalence of resistant hypertension varies depending on the population that you're looking at. This table shows the estimated prevalence from various population-based studies, as well as clinic-based studies and clinical trials. And you can see from the column all the way on the right, which shows the percent of apparent treatment-resistant hypertension. Depending on the population, this varies anywhere from around 10% all the way up to perhaps 40%. The populations that seem to have the highest prevalence of treatment-resistant hypertension are those patients who have chronic kidney disease, as well as studies that have been enriched for patients who have cardiovascular disease already, stroke, etc. And remember that patients who have resistant hypertension are more likely to have a secondary cause of their hypertension, and they're more likely to have medication adverse effects, probably because they are on more medications than other patients that we're treating with hypertension. What is the definition of resistant hypertension? How do we identify this in patients? So the accepted definition is a blood pressure that is elevated above goal, despite the use of 3 antihypertensive medication drug classes. And these medication classes are typically one of the following, although they do not have to be: a long-acting calcium channel blocker, a renin-angiotensin system blocker, as well as a diuretic. And it is important to remember that these medications must be dosed at either maximum or maximally tolerated doses to actually identify or call someone a resistant hypertensive. Now, among the patients that you identify as having resistant hypertension, what we actually call them first is apparent treatment-resistant hypertension, because among those patients that fit the criteria that I mentioned on the previous slide, there is going to be a subset of these patients that have what we call pseudo-resistant hypertension. So this is not true resistant hypertension, but it's hypertension that appears to be resistant because of various factors. And I typically think of these factors as fitting into one of 4 categories: either inaccurate blood pressure measurement, the white coat effect, medication non-adherence, or undertreatment of hypertension by the treating clinician. So inaccurate blood pressure measurement and white coat effect are things that we should be identifying in all patients who have hypertension. And I'm not going to focus in on those today, but again, those are things that require appropriate and accurate measurement of blood pressure in the clinic and at home, as well as using out-of-office blood pressure measurements such as ambulatory monitoring or home blood pressure measurement. But I want to discuss a little bit further the importance of identifying medication non-adherence and undertreatment in apparent resistant hypertensives. Among patients who appear to have resistant hypertension, medication non-adherence is actually very common. And I'll share with you two studies that illustrate this important point. So this data comes from a study that used directly observed therapy among patients who had apparent resistant apparent resistant hypertension, and they had been excluded for secondary causes of hypertension. These patients had ambulatory blood pressure monitoring done at the start of the study, and then after just 1 day of directly observed therapy of their prescribed medications, they had ambulatory monitoring repeated. And what these investigators found was that 50% of the patients that were included in this study had a significant drop in their 24-hour ambulatory blood pressure just after taking their prescribed medications, after someone watched them take these. And that's the data that you'll see on the left in this figure. Not all of these patients reached goal after taking their medications, but a significant number of them had blood pressure that dropped to a notable degree. The mean drop in the 24-hour ambulatory blood pressure was 19/9 millimeters of mercury. So 50% of these patients in this study, and it's been repeated in several other studies in different populations with similar estimates, had at least some degree of non-adherence to therapy that is contributing to what we think is resistant hypertension. Investigators have also used urine toxicological analysis to identify non-adherence. And this is a figure that comes from one such study in which patients who had apparent resistant hypertension who were excluded for white coat effect and a secondary cause of hypertension had their urine assayed for metabolites of almost every single medication that they were supposed to be taking, that they were prescribed. And they found that 53% of patients, so over half of these patients, were non-adherent to at least one of their medications. Most of the patients, as you can see in this figure, were taking less than 50% of their prescribed drugs. And what's really striking to me is that 30% of them were taking none of their medications, at least as assayed by urine toxicological analysis. So this is a really important point to remember, not only in patients who have essential hypertension, but especially for patients that you are going to give this new diagnosis of resistant hypertension to. Really important to exclude non-adherence because it's very common. And once patients can become adherent to a regimen that they prescribed, their blood pressure often drops, maybe not to goal, but by a significant degree. So this is beyond what I want to focus on today, but I just wanted to include a slide here on how do we identify non-adherence and how do we correct non-adherence, because I think that this is something that is best done in a multidisciplinary manner. I think the treating clinician or physician is only a piece of this, and it requires a lot of people to help identify and correct non-adherence. But one of the things that I do, and that's commonly recommended for assessing non-adherence beyond even the hypertension literature, is just direct assessment of the patient, directly questioning them, kind of assuming that it is probably easy to miss medication. So I often ask patients, when taking multiple medications, it's common to miss doses or common to take them at times not prescribed. How many times a week does this happen to you? And you'll often get a lot of really important information from that. There are also validated scales, which I think are less easily used in the clinical world, but these are often used in research settings. Pill count is something that is has traditionally been used, but I think is sometimes a little challenging to do, but this is again an option. Prescription refill data, especially if this is something that's linked to your electronic health record, can be quite illustrative. And then there are some clinics that have the ability to directly measure urine or blood drug metabolites. But many people do not have access to this. And if you do have access to this, this can also be a really powerful tool to, in the right patient, to help identify, but also help patients become adherent. And so there's several strategies that are effective in the general hypertensive population that can be extrapolated to the resistant hypertension population to correct non-adherence. These are some of the ones that I do for my patients. I try to use medications that are dosed once a day. It's hard enough for patients that are taking 10, 15, 20 medications to be taking them multiple times a day. So really trying to use medications that are daily dosed. Combination agents can be really powerful. And I know that this limits sometimes titration of medications or the specific drug that you want to use, but becoming familiar with at least a handful of combination pills that are often quite inexpensive for some patients, this can be really helpful. And then something as easy as 90 versus 30-day prescriptions to consolidate refills, consolidate when patients actually have to go to the pharmacy to pick up their medications can be helpful. So there's a lot of other things that are beyond the scope of my talk today, but I wanted to make sure that I mentioned some of these because non-adherence is so common in resistant or apparent resistant hypertensives. Another common cause of pseudo-resistant hypertension is undertreatment by clinicians, by physicians, not having patients on appropriate drug regimens or maximally tolerated doses. And this is a figure that I took from a study that was actually looking at inaccurate blood pressure measurement and how that contributes to pseudo-resistant hypertension. But they created this figure and included other causes of pseudo-resistant hypertension. And you can see that undertreatment here is quite prevalent. The data here primarily comes from a single study, which I'll share with you on the following slide. So this was a study that aimed to identify the prevalence of optimal treatment regimens in patients who had apparent treatment-resistant hypertension based on office blood pressures in a practice network of several 100 community-based clinics. And these researchers identified just over 150,000 uncontrolled hypertensives in this database. Of those patients that were uncontrolled, just over 44,000 or 30% of them were prescribed at least 3 antihypertensive medications. And then they looked at those patients and they looked at their prescriptions and determined how many of those were actually on optimal therapy. And they defined optimal therapy as being on at least a diuretic and 2 other medications that were dosed at least 50% of maximal doses. And they found that of those 44,000 patients, only half of them were actually prescribed optimal therapy. So 15% of that total population that they looked at. And so we have, there is significant room for improvement for optimizing that 3-drug regimen before you actually call someone a resistant hypertensive. So that summarizes the first part of what I wanted to talk about today. So we've discussed how do you define resistant hypertension, and then how do you exclude what's called pseudo-resistant hypertension, specifically identifying non-adherence and making sure patients are on optimal regimens. So once true resistant hypertension has been confirmed, the next step that I look towards is identifying and treating contributing causes, including secondary causes of hypertension in these patients. The first thing that I always do is going right to their medication list. As you probably know, there are many medications, whether they're prescribed or over-the-counter medications, that contribute to hypertension. And many patients don't actually know that medications that they're prescribed by other providers or that they may be taking over the counter can exacerbate their hypertension. The biggest one for me, especially as a nephrologist, that I'm always asking about are NSAIDs. These are medications that are known to contribute to hypertension, and something that patients who appear to have resistant hypertension should really not be taking. This is not an exhaustive list, but this includes a lot of the medications that I always look for. Things such as caffeine are really common as well. Decongestants are another medication that many patients may not understand are contributing to hypertension. So looking through their list, some of these medications are maybe things that you can't stop, but at least modifying doses as possible or stopping medications that really can be stopped can be helpful for these patients. Now, what about an appropriate evaluation for secondary hypertension? This in and of itself is a huge topic. And so I don't want to go through all of the causes of secondary hypertension, but I pulled out what I think are the most important causes that we should be considering in patients who have resistant hypertension. And so I have 4 of them here. One of them that I didn't include on this slide is chronic kidney disease. Chronic kidney disease is commonly seen in patients who have resistant hypertension, but it's something that we can't, at least as of now, don't have a specific treatment for, so I didn't include that in this table. But these are the 4 causes that I think are really important to make sure that we're not overlooking in patients who have resistant hypertension. The first is renovascular disease. Several clinical features, I'm sure as many of you are aware of this, are patients who have atherosclerosis, patients who have vascular disease elsewhere. These are patients that we often will coin as being vasculopaths. One of the common phenotypes that not all patients with renovascular disease have, but can be seen, is recurrent flash pulmonary edema, especially in the setting of paroxysms of hypertension. Now, screening tests for this are as follows. These are imaging studies. I typically start with a renal duplex Doppler ultrasound. Now, it's important to remember that this is operator dependent. So depending on your ultrasonographer, the technician, the radiologist that's reading this, if they are doing an adequate and appropriate job with these measurements, this is something that is appropriate to use. But again, it is operator dependent to get a good Doppler ultrasound. Now, a positive Doppler is much more helpful for you as opposed to a negative Doppler. So if you still have a really high index of suspicion or a high pretest probability that one of your patients has renovascular disease, moving towards an MRA or abdominal CT scan is something that would be done next after a potentially negative or inconclusive Doppler ultrasound. Obstructive sleep apnea is something that we should be screening for in every patient who has resistant hypertension. Many guidelines support this. This is something that I see quite commonly, and this is what I do for all of my resistant hypertensives. Several clinical features, I'm sure as you also are aware: obesity, snoring, daytime sleepiness. If you've done ambulatory blood pressure monitoring for patients, non-dipping hypertension or nocturnal hypertension is not uncommon in patients who have obstructive sleep apnea. So getting a sleep study in these patients is the screening test, or at least the diagnostic test as well. And I have a couple slides on this going forward. Primaryaldosteronism is something, again, that all patients with secondary hypertension need to be screened for. Many patients have no specific clinical features other than being hypertensive. But the classic feature of hypokalemia, either induced by diuretics or spontaneous, can be seen. This is also commonly associated with sleep apnea and atrial fibrillation. The classic screening test for this is the aldosterone to renin ratio. And I put an asterisk here because I'll share in a few slides going forward that there are a lot of caveats to this test, and there are that I want to make sure that I emphasize for you all. And then finally, just a brief word on pheochromocytoma paragangliomas. These typically have clinical features such as paroxysmal hypertension, labile blood pressures, headaches, palpitations, sweating. So these are something that are usually easier to identify, but in patients who have resistant hypertension, I think it's reasonable to screen most of them for a pheochromocytoma or paraganglioma. So as promised, I wanted to pull up just a few slides about obstructive sleep apnea and resistant hypertension, since this is so prevalent. Depending on analyses that you look at, there's several studies out there that have aimed to identify the prevalence of disordered sleep breathing or obstructive sleep apnea in resistant hypertensives. You can find anywhere from 55 to 83% of patients will have obstructive sleep apnea. At least in one single center study that I put the figure on the bottom of this slide from, obstructive sleep apnea was identified in 64% of patients in this single center who had resistant hypertension and were referred to a resistant hypertension clinic. It was the most commonly identified secondary cause of hypertension, at least in this cohort. Now, the data for using CPAP, continuous positive airway pressure, to treat obstructive sleep apnea and to lower blood pressure in the general hypertensive population is mixed, but at least it appears that in resistant hypertensives, there is a more significant blood pressure lowering effect of using continuous positive airway pressure in our patients with obstructive sleep apnea. The data that I have here is from an example randomized clinical trial. And the figures here show the changes in diastolic, systolic, and mean 24-hour blood pressure as a function of the time that patients were using their CPAP overnight. And you can see that appears to be this linear relationship between duration of CPAP use and blood pressure lowering. And the actual magnitude of blood pressure lowering is not insignificant. So patients that have resistant hypertension, I think if you identify obstructive sleep apnea, using their CPAP is really important, and another way that we can at least lower their blood pressure to some degree. Primaryaldosteronism is actually one of my favorite topics to talk about, and there's a lot that we could discuss, and I've tried to narrow this down in just to a few slides for in the context of resistant hypertension. This is something that is generally under-recognized. we can identify biochemically overt primary aldosteronism actually across the entire spectrum of patients with hypertensive disorders, not just in patients who have resistant hypertension, but among patients who have prehypertension, patients that have stage 1 hypertension, and even in normotensives. And I want to share data from this really nice study that was done several years ago. It was a cross-sectional study that aimed to identify the prevalence of primary aldosteronism, primarily by using urinary aldosterone measures. And they gathered data from 4 separate cohorts, one of which included a cohort of resistant hypertensives. This is one of the figures from their study. And if you look all the way to the right is the data from the cohort who had treated resistant hypertension. And in these patients, they found a significant proportion of them who had suppressed renin levels, had an elevated 24-hour urinary aldosterone excretion. And the typical cutoff that's generally accepted is 12 micrograms of urinary aldosterone per 24 hours. But over 50% of the patients who had resistant hypertension in the cohort that they studied had renin-independent aldosterone secretion. So aldosterone secretion that is not physiologic, and that you would actually consider it as primary hypertension or as primary aldosteronism, excuse me. So as I mentioned, we should be screening for primary aldosteronism in all patients who have resistant hypertension. And there has been various studies, abstracts that I've seen at conferences that have looked at what are the current screening rates, and they're really abysmal. Some of these studies suggest that current screening rates are as low as 2% in patients who have resistant hypertension. So this is something that we really need to be increasing knowledge of and screening for, because there is, for the appropriate patient, a treatment that can be, or at least a couple treatments that we can use for primary aldosteronism. The most widely accepted screening tool, as I mentioned earlier, is using the aldosterone-renin ratio. And the most commonly accepted threshold is a ratio of greater than or equal to 30 in the context of a suppressed renin. And now, how do you define a suppressed renin? That's something that is really not set in stone, but generally of a very low renin level, but also with an aldosterone concentration of over 15 nanograms per deciliter. But it's important to note that you can even see confirmed cases of primary aldosteronism just by using the phenotype of a suppressed renin and then urinary aldosterone levels in the context of salt loading, even in patients who have serum aldosterone levels that are below that threshold of 15, even as low as under 10. So these thresholds are not something like yes, no. If you get a ratio that's a little bit lower than 30, definitely don't rule out primary aldosteronism. I think it's important to do a confirmatory test in patients, even if you have a high enough suspicion. And I would argue potentially for all resistant hypertensives, unless their renin level is really, really high, getting a confirmatory test might actually be helpful. So people always ask, what drugs do we stop? How do we adjust the regimen? We don't want to have them on interfering drugs. And in general, what I actually say is, at least for the start, if you have a patient in the clinic who's going to be getting labs for you that day, unless they're on a mineralocorticoid receptor antagonist already, which you definitely need to stop, don't worry about stopping other drugs initially. If these patients, in the context of their current antihypertensive regimen, have a random plasma renin activity that's already suppressed, this is strongly suggestive of primary aldosteronism. As you can recall, or as you may recall, angiotensin receptor blockers and ACE inhibitors can raise the renin. So if a patient is taking this and the renin is still suppressed, highly suggestive of primary aldosteronism. Now, the typical test for confirming aldosteronism is salt loading, either IV or oral salt loading, and then getting a urinary 24-hour urinary aldosterone. And just a point about salt loading, most of our patients, even if they tell you that they're on a low sodium diet, actually have a lot of sodium as well in their diet and are probably salt loading themselves already. So as a nephrologist, I get 24-hour urines all the time, and I'm often getting 24-hour sodiums for patients, as an aside, who have stone disease. And even for those patients that tell me, yep, I'm on a low salt diet, I will see a really high urinary sodium. And when a patient is in steady state, that urinary sodium is exactly equal to what they're taking in. So when you're getting a 24-hour urinary aldosterone, I also add on a 24-hour urinary sodium. And for many of these patients, you'll see that even on their normal diet, where you just tell them eat a bit more salt than normal, you'll find that their urinary sodium excretion can reach that threshold of above 200 milliequivalents per 24 hours, which would be adequately salt loaded. I don't often do IV salt loading, but that's an option. And then even using something like salt tablets if you want to supplement a patient's diet. Obviously, there's some concerns here. Are you going to contribute to more severe hypertension? So you have to kind of look at the patient in front of you and make sure that you're not raising their blood pressure, spiking their blood pressure with a significant salt load, which is why I like to avoid IV sodium loading. But this 24-hour urine sodium can be really helpful in this context. So I'll mention lifestyle and diet actually just briefly here, because I really want to focus on medications. And again, I think lifestyle and diet obviously is hugely important, but this is something that I think really requires a multidisciplinary approach. And I wanted to focus in on more what kind of treating and prescribing clinicians can do for resistant hypertensives. But in terms of lifestyle and diet, dietary sodium restriction is important. And studies that have looked at sodium restriction in resistant hypertensives, we know that this lowers blood pressure. When you restrict dietary sodium to 50 millimoles per day, which is very low, that's under 1,200 milligrams of sodium per day, this decreased office blood pressure in at least one study by over 22.7 millimeters of mercury for systolic blood pressure and almost 10 millimeters of mercury for diastolic blood pressure. So significant blood pressure lowering effect. And even a little bit less stringent sodium restriction, just under 2,000 milligrams per day, has significant blood pressure lowering effect. And this was in patients who have stage 3 or 4 CKD, but a lot of those patients have resistant hypertension anyway. And another mention about the 24-hour urine sodium excretion here. So this is something that can actually be helpful for patients to, if you have someone who's really motivated to lower the sodium in their diet and want to know, am I lowering it enough? Am I doing a good enough job? You can obtain a 24-hour urine sodium on their typical diet for a day. And remember, when they're in steady state, whatever goes in comes out. And so if their sodium excretion is low there, you'll know that they're appropriately sodium restricting themselves in their diet. Now, the DASH diet in particular, which we prescribe for a lot of patients with essential hypertension, it's not actually been studied specifically in resistant hypertension, but I think it is very reasonable to assume that this is something that we can extrapolate data from for our resistant hypertensives. So finally, getting to the meat of what I wanted to talk about today is medications and a brief talk about devices and interventions in the management of resistant hypertension. So this is an algorithm that comes from the American Heart Association scientific statement on resistant hypertension. If you want to look this up, from Hypertension 2018 is when the publication came out. But I really like this algorithm for a few reasons. One is it's something that I do and I follow. Two is I think it's really easy to follow. And it really focuses in on that first step, as you can see on the top left, on making sure that you're identifying a patient with true resistant hypertension, excluding other causes such as the white coat effect, medication non-adherence, excluding secondary causes that we went through. Optimizing that 3-drug regimen is really important before you label a patient as having resistant hypertension. And then really counseling patients on those lifestyle interventions, some of the ones that I didn't go through today, but are allowing for good sleep habits, dietary patterns, which I mentioned, low sodium diet, as well as the DASH diet, weight loss, and even exercise without weight loss. All these things that we're doing for all of our hypertensives, we should be doing for resistant hypertensives. So if all of these things you've done for a patient, you've identified them as having truly resistant hypertension and need to add on a medication, what do you do next? And so that's what I'm going to talk about in the next several slides. So first is to make sure that you're optimally dosing a diuretic and using the most appropriate diuretic, which is usually a thiazide-like diuretic or a loop diuretic for patients who have reduction in their GFR. If the blood pressure is still not at target, this is where you add a mineralocorticoid receptor antagonist, spironolactone or eplerenone. And based on published data to date, this is the best 4th drug that we have for most patients who have resistant hypertension. And after that, if the blood pressure is still not at target, the rest of the recommendations are primarily based on expert opinion and less from randomized, robust clinical studies. But most of these medications, such as the beta blockers, hydralazine, minoxidil that you'll see highlighted here, aim to address the sympathetic nervous system. So the way that I like to think of this is as follows. For most patients who have resistant hypertension, if you've not identified a secondary cause or other contributing cause, this is usually mediated by one or all of the following factors. The first is volume excess. So again, as a nephrologist, so I know I have a bit of a bias here, but most of my patients, much of their hypertension is mediated by volume excess. But even for patients who do not have kidney disease, volume excess is a huge mediator of hypertension. And we address this aside from lifestyle and diet with diuretics. Second is aldosteronism. So even patients who do not clearly have primary aldosteronism, aldosteronism or renin-independent aldosterone secretion clearly follows this spectrum of disease. And like I had mentioned, it's not yes, no, there's a clear spectrum of inappropriate aldosterone secretion. And so for resistant hypertensives, the mineralocorticoid receptor antagonists can be highly effective. And then finally, increased sympathetic tone. And this is a factor for a variety of reasons. You can see this in patients who have sleep disorders, such as obstructive sleep apnea. Anxiety plays a role. Obesity definitely plays a role in increased sympathetic tone. And this is something that we're usually targeting with beta blockers or similar medications. So I'll go through each of these stepwise. So the first are the diuretics. And it is important to remember that our diuretic of choice are the thiazide-like diuretics, which are chlorthalidone or indapamide. I think indapamide is less commonly used, but this is an appropriate medication to be using for patients as well. So in contrast to the thiazide diuretic, which we often see hydrochlorothiazide, these have greater potency. They also have longer half-lives, and so perhaps these will exert improved nighttime blood pressure control. There are some patients who have a non-dipping phenotype of their hypertension where blood pressure normally drops at night. And some people, their blood pressure does not drop appropriately at night. And there's actually some patients who have reverse dipping where blood pressure rises at night. And so there's not clear trial data that these medications can do this with clear outcomes, but because they have longer half-lives, perhaps they might exert improved nighttime blood pressure control. And meta-analyses have shown that the reduction in cardiovascular events, as well as reduction in heart failure for these thiazide-like diuretics was significant irrespective of adjustment for blood pressure. So remember, if you have a patient who's on a diuretic, if they're on hydrochlorothiazide, definitely change them over to chlorthalidone or indapamide and make sure that you're using the maximally tolerated doses for these patients. People always ask me, when do I substitute a loop diuretic or when do I add in a loop diuretic? Is there a GFR threshold? And what I typically say is once the GFR drops under around 25 to 30 mils per minute, that's when a loop diuretic might be beneficial for your patient. You can either add a loop diuretic to the thiazide or substitute a loop diuretic for the thiazide diuretic. My loop diuretic of choice is torsemide. This is something that can be dosed daily for hypertension. If you're using furosemide for hypertension, furosemide really should be dosed twice a day. And because I'm a huge advocate for once daily dosing, I typically go straight to torsemide unless there are other reasons to use furosemide. We titrate these similar to our treatment of heart failure to what we think is an effective dry weight for patients. And there is some more recent data that the thiazide diuretics actually, or the thiazide-like diuretics, actually exert a significant antihypertensive effect even in patients who have CKD4, so GFRs under 25. So again, you can add a loop diuretic, especially for a patient that looks to be volume overloaded to the thiazide diuretic, but sometimes you run into problems with more pronounced hypokalemia or hyponatremia, in which maybe you just want to get rid of the thiazide-like diuretic altogether. And so loop diuretics are really important and for patients, especially who have other reasons for volume excess or chronic kidney disease. So next are the mineralocorticoid receptor antagonists. Spironolactone Eplerenone is another medication that is used less commonly, but is also another MRA that we can use for resistant hypertension. Spironolactone is my go-to. It's a daily dosed medication. Eplerenone is twice a day. Spironolactone can sometimes have unpleasant side effects, for example, gynecomastia. But spironolactone is what I typically go to. And as I mentioned, even in patients who do not have clear primary aldosteronism, MRAs are the best fourth drug for resistant hypertension. And the data for this primarily comes from the Pathway 2 trial. And I'm also going to share a little bit of data from what is known as the AMBER trial. So the Pathway 2 trial was a randomized double-blind crossover trial that aimed to determine what is the optimal fourth medication for patients who have resistant hypertension who are already on optimal 3-dose regimen for their blood pressure. And patients here were randomized to receive in sequence and rotating sequence to either placebo, spironolactone, doxazosin, or bisoprolol. And I'll mention here that this study excluded patients who had known secondary hypertension, so known primary aldosteronism, to be able to enroll in this trial. And spironolactone came out as the winner. This lowered the blood pressure by a significant degree compared to the other regimens. So this was the best drug as the fourth medication to add to the 3-drug regimen among all patients. So what I find really interesting about this is spironolactone worked even across all renin levels. So the investigators in this study measured baseline renin levels in these patients, which is seen here on the x-axis. And you can see that spironolactone, which is in this pink or kind of peach colored line, worked best at suppressed renin levels, which makes sense because patients who have some degree of aldosteronism, renin-independent aldosterone excretion, are those patients that have really low renin levels. So spironolactone would be expected to work better in these patients. And it was actually the best medication across all renin levels, except for the very, very highest, I think it was like 2 to 3% highest renin levels in this study in which bisoprolol worked better. But even across patients who have higher renin levels that, again, don't appear to have this phenotype of renin-independent aldosterone excretion, spironolactone is the best drug to add. So as you may know, one of the limitations to using spironolactone are the side effects of hyperkalemia, especially in patients who have chronic kidney disease. And so the AMBER trial was a randomized, double-blinded, placebo-controlled trial that aimed to determine if we can add patiromer, which is a potassium-binding resin, to spironolactone in patients who have chronic kidney disease and resistant hypertension, and if this would enable patients to stay on spironolactone longer. So what the investigators did was they took patients who had chronic kidney disease and the GFRs, I apologize, I can't recall the exact ones off the top of my head, but these were patients who had kind of early stage 4 or later stage 3 chronic kidney disease. So these would be the ones that are at risk for having hyperkalemia and had resistant hypertension, already on a good regimen. And they randomized them to either spironolactone plus placebo or spironolactone plus patiromer, which is that potassium binding resin. The patiromer dose was actually the lowest dose. Patiromer, for those of you who do not have familiarity or not been using this, comes in kind of like a low, medium, and high dose. And so this was the lowest dose of patiromer. And the spironolactone dose was actually relatively low in this study as well. And by the 12th week of the study, 86% of patients in the patiromer group remained on spironolactone, which was significantly higher than the number of patients in the placebo group. And the primary reason for stopping this was hyperkalemia. The cumulative dose of spironolactone was higher with patiromer than with placebo. But it's important to note that the outcome of this study was not to look at blood pressure control. However, they said that there was no significant difference in office blood pressures from baseline to week 12 between the two treatment groups. But using patiromer is a possible way that we can enable patients to stay on spironolactone if this is providing excellent blood pressure control, especially if they're having the side effect of hyperkalemia in the context of chronic kidney disease. So I don't often like to add a medication to because you're having a side effect from another medication. I think that's one of these kind of things that a lot of us learn early on when we're treating patients. But here, because spironolactone can be so helpful for patients and for their blood pressure control, adding a low dose of patiromer, I think is reasonable and is something I have done for my patients and enabled them to stay on spironolactone for a longer time. Now I'll briefly mention the additional add-on therapy here, because as I mentioned, all of these medications are probably interchangeable, and what you use next is going to depend on what patients respond to. Do they have other comorbidities for which maybe they need to be on a beta blocker, etc. So beta blockers are another add-on therapy. Typically, we prefer combination alpha and beta blockers because they exert a greater antihypertensive effect. And many of these medications are dosed 2 or 3 times a day, so that's a little bit more challenging for patients. But beta blockers are a good add-on therapy, especially for patients who kind of fit that phenotype of having elevated sympathetic nervous system activity. The central alpha antagonists are also medications that we can use. Clonidine, I typically use the clonidine patch just because of ease of use. Or guanfacine is something that I think is much less commonly used. This is something, if you're going to use it, you should be using at bedtime because of the sleepiness side effect that can occur with this medication. And then hydralazine or minoxidil are also medications that you can use as add-on therapy. These medications do require the use of a beta blocker and a diuretic, though, because those medications can cause reflex tachycardia and fluid retention. So being on a beta blocker is really important, as well as a diuretic. And usually this needs to be a loop diuretic, especially for minoxidil. So minoxidil is one of those things that, again, I more commonly use in my patients with advanced CKD or ESRD. But if you're going to be using this in resistant hypertensives who do not have CKD or maybe mild CKD, make sure that you have a patient on a beta blocker and a diuretic, which hopefully you will already, but probably needs to be a loop diuretic in the context of minoxidil. So finally, I wanted to mention device-based treatment or procedures, which are the two that I'll mention are renal denervation and carotid Barrow reflex activation therapy. So renal denervation, at least in several studies, appears to lower blood pressure, okay? However, this is something that has not been proven in several trials to be an effective therapy for resistant hypertension. The 2 studies that I'll share here are probably the best data that we have. The first study is the Simplicity Hypertension 3 study, which randomized patients with resistant hypertension already on a good drug regimen to either renal denervation or a sham procedure. And they actually found no significant difference in blood pressure control. The Diener hypertension trial was an open label randomized control trial. And this trial did show that renal denervation did lower blood pressure. However, there was not a sham procedure in this trial, and there were several other methodological concerns. The blood pressure seemed to be a bit higher in the group of patients who had renal denervation at baseline. So while there is some suggestion that renal denervation might be helpful, we don't have proven effectiveness as of yet. Now, what about Barrow reflex activation therapy or carotid sinus baroreceptor stimulation therapy? So the best data for this comes from the RIOS pivotal trial, which I've put here. And as you can imagine, the goal of Barrow reflex activation is to inhibit the sympathetic drive and enhance parasympathetic activity to lower blood pressure. Now, this trial actually did meet several outcome measures. The long-term efficacy of this device, and it was a device that was implanted in patients. The long-term efficacy of this was met, but not all of the outcome measures were met, such that the FDA did not approve this this device. But essentially what they did in this study was they implanted all patients with this Rios device that was a Barrow Reflex activator, and randomized them either to having it activated initially or waiting 6 months until activation. And they did find significant blood pressure lowering over the course of the trial, appeared to be safe, but there was no short-term, they did not meet the short-term efficacy outcome, and there were also procedural complications, and as such, this was not approved by the FDA. But there are changes to this device that are ongoing, that hopefully this is something that we may be seeing more of in the future, because anecdotally, there are patients that did have significant blood pressure lowering. And I'll share just a slide here, which is from a different study that was published just I think a year earlier than the one that I just mentioned, that showed sustained reduction in blood pressures at 1 and 2 years in patients who had this device or baroreceptor stimulation. So this is a therapy that I think has great promise that we should be looking forward to in the future. So I'll leave you with this. These are some of the clinical pearls that I've hopefully emphasized today with regards to the treatment of resistant hypertension. And in the interest of time, I'm not going to read through all of them. But thank you for your attention. And I know that we have some time for questions, and so I'm happy to answer any questions that come up. So I will stop my screen share so maybe so you can see me a little bit better, and happy to answer any questions. Thank you so much for your time and attention.
Thank you so much, Dr. Drury. We do have a couple questions in the chat box. I am going to start off with the first one. Was there a review on true RH breakdown based on age, gender, ethnicities, socioeconomic immigration status?
Okay, that's a really great question. I do not know of one off the top of my head that I can reference for you, but we do know, at least based on several of the studies that I shared early on, some of the cohort or population-based studies, especially the NHANES database and regards, that it appears that resistant hypertension is more common in certain races or ethnicities compared to others. The caveat to that is most of these like population-based studies, we have to denote resistant hypertension as being apparent treatment resistant, because the data gathered here is patients who appear to have resistant hypertension, but we don't have great data on patients who have gone through a thorough workup for non-adherence, et cetera. But at least from the population-based studies that I'm aware of, it does seem to be that in certain racial groups and ethnicities, this is probably more common. Now, reasons for this is multifactorial, but I can't think of a single one off the top of my head.
Okay, thank you. Next question here is, would you mind reviewing your opinion on when PCP should refer to renal for further management?
Okay, thank you for that question. And I appreciate you asking about nephrology, because I love working with my cardiology colleagues. I think cardiology often gets a lot of resistant hypertensives, but in my opinion, so I would say anyone who has chronic kidney disease, who appears to have resistant hypertension, so meets those criteria that I mentioned, you already have them on a great 3-drug regimen, definitely send them to me. Even if they have mild chronic kidney disease and they're not really seeing a nephrologist yet for that, I think sending to a nephrologist is completely appropriate. We are happy to see patients for treatment of this. Even patients without chronic kidney disease, I think nephrologists, many of nephrologists are happy to see patients for resistant hypertension in combination with cardiology colleagues. But if there's ever a question, I think any referral we're happy to see, but definitely if they have any degree of chronic kidney disease and they appear to you as having resistant hypertension, we can definitely go through those excluding pseudo-resistant hypertension, et cetera, excluding white coat effect if that's not something that you're able to effectively do as a primary care provider. But again, I think anyone, even with mild chronic kidney disease, we are very happy to see to help out. Thank you for that question.
Dr. M, I'm going to throw this next question from Lee over to you if you want to read that out.
So the patients who would benefit from treatment with spironolactone despite hyperkalemia with the use of the potassium binders. I think that as we mentioned, spironolactone is a good addition to patients with resistant hypertension. A significant proportion of patients have the primary hyperaldosteronism. However, I'm very careful with continuing spironolactone or eplerenone in patients who do have hyperkalemia, mostly because of the worry for non-compliance with diet and the follow-up. I think the use of the potassium binder could be used, but myself, I am a little careful with that because we don't know if the patients will follow up on time, especially if they have a poor access to medical care. At the University of Rochester, we have a big population of patients who come to us from the far away areas, and they have blood work done in the local laboratories. So I myself don't like to use that in the patients who have hyperkalemia. I don't know, Erica, if you have any other opinions.
Yeah, I would say if you're thinking about using patiromer, this is, as an aside, this is a medication that can be costly for patients and may often require prior authorization, which as nephrologists, we're used to doing that. And so if you're concerned about hyperkalemia and thinking about patiromer, I think that's a definite reason to refer to nephrology, because we are much more comfortable with a mild degree of hyperkalemia, I think, than others. But again, as Dr. Hannah mentioned, patients need to be counseled a lot about the risk of hyperkalemia, about appropriate diet. A lot of the, DASH diet, heart healthy diet is very high in potassium, which is really challenging for patients. But if you're thinking about starting patiromer for a patient, I would definitely have them see nephrology, especially because we're, I think, a little bit more comfortable with managing this and using patiromer and titrating it up. I'll mention, just as an aside, there's a new non-steroidal mineralocorticoid receptor antagonist called finerenone that is currently being studied in patients. This is for a separate indication, but patients with CKD and proteinuria that does not have the same hyperkalemic effects as spironolactone. So perhaps in the future, we're going to be seeing this as a medication for resistant hypertension that hopefully we can ameliorate that hyperkalemic effect.
Great, thank you, Dr. Drury and Dr. M. Are there any additional questions from anyone? And you can also raise your hand at the bottom of your Zoom controls, and I can take you off mute if you'd like to ask your question in person, voice to voice.
I just had a question in regards to the NSAID precaution. I know that's always been a precaution, but anecdotally, I find very few patients that have that very clear relationship with the NSAIDs. But also, I was wondering any opinion on any difference with different NSAIDs in terms of if there's going to be an effect on the blood pressure, shorter term one versus a longer term one, or PRN or any use.
Okay, thank you. That's a great question. I will tell you, I don't know if there's great data for that, but at least anecdotally, if you have a patient who has resistant hypertension that is now you've controlled, and they have an injury and they need short-term, short-acting NSAIDs, I think that you could probably use that. But just remember that you should tell your patients, check your blood pressure at home. I mean, we should be advocating for home blood pressure monitoring anyway, but monitoring blood pressure at home if they're going to be on a really short course of NSAIDs. I think, long-term use of NSAIDs, I would highly discourage. But short-term use, as long as the blood pressure is under reasonable control before starting them, I think is reasonable. You have to kind of think about risk benefit to the patient. We know NSAIDs are great pain medications as opposed to other things. And, with the opioid epidemic, we're trying to avoid those if possible. And acetaminophen doesn't seem to work as well for some patients. But I think the shorter acting ones, I'll mention now that I'm thinking of it, topical NSAIDs are completely appropriate and acceptable to use for patients. There's such minimal absorption through the skin of those. So those I am always completely fine with for these patients. Hopefully that answered your question.
Perfect. Thank you to Dr. Drury and to all our attendees today. This was a great discussion. We've got a little bit of time before your main session. So now it's time to head back to the main room.
I wanted to
go ahead.
make one comment. I sent a nice American College of Cardiology update on racial disparities to the chat box. So if anyone would like to review, it is really nice kind of summary of that.
Great. Thank you, Dr. M. Did you send that to the main group?
I sent it to the chat box. So let's see.
I think if you just click when you go into the chat where it says to, just make sure that it's going to everyone.
Okay. Sounds good.
All right, perfect. Again, thank you, everyone. Thank you, Dr. Drury, Dr. M, and all of our attendees for joining today. So you can head back into the main room now. To do that, just use the same link that you used for the beginning of the summit this morning, and we'll get started there at 11 a.m.
Thank you.
Thanks, everyone.